I want to talk about the timeline for in vitro fertilization. I'm Dr. Sharon Moyeri, owner and founder of OC Fertility. So a lot of people think that in vitro fertilization is a long process, and in fact, it's probably quicker than you think. The first step is getting your testing done, and generally that can be accomplished within 1 month. The next step is starting treatment. We usually use your menstrual cycle to begin treatment because it's a convenient starting point. You'll come in on your menstrual cycle. We generally do a baseline appointment. At that appointment, most doctors are going to do a pelvic ultrasound, which sounds sometimes weird to people to be doing a pelvic ultrasound when you're on your period, but that's very normal for us as fertility doctors. We're going to be looking at your ovaries, making sure that it's okay to start the medications. If everything looks good, you'll start injection medications, anywhere from 2 to 3 injections typically per day, either in the morning or the night, depending on your doctor's protocol. You may be also taking some pills. Again, these are protocol specific, but expect to be injecting yourself with medications. The medications are given what are called subcutaneously in the belly fat or the thigh fat mostly. And then you'll be coming in for what are called monitoring appointments. What does that mean? You'll be getting pelvic ultrasounds and blood tests, and the frequency really varies on the specific doctor and the protocol. Expect to come in for those next 10 to 14 days, anywhere from, I'd say, 4 to 8 times, depending on the protocol. And you'll be getting monitored with either pelvic ultrasound and or blood tests. The blood tests are usually looking at estrogen hormone called estradiol, progesterone hormone, and sometimes other hormones like luteinizing hormone. The point of doing those tests is to figure out when's the best time to extract the eggs. And so what we're also doing is measuring the follicle size, and the follicles are the cysts that house the eggs. So inside each follicle resides 1 egg, and as the eggs mature, those cysts get bigger. Typically the cyst reaches about 2 centimeters when the eggs are mature and ready to be extracted. When the eggs are ready to be extracted, the fertility doctor will go in with a small needle about the size of the tip of a pen, and through the back of the vagina, using an ultrasound, will pass the needle into the ovary and extract the eggs by puncturing those follicle cysts. It's a very simple procedure, and you'll be under anesthesia typically for this procedure, and you want to be asleep because it can be uncomfortable having a needle obviously going through the back of the vagina, but it takes about 20 to 30 minutes to do the surgery, and you'll go home the same day. Once we have the eggs, we'll combine it with sperm if you're creating embryos, and if you're not creating embryos, then we'll freeze whatever eggs we extract. Because we know that human reproduction is fairly inefficient, and it becomes more inefficient the older you get, meaning you usually need a lot of eggs and a lot of sperm to create a healthy embryo, and the older we get, the less healthy those eggs and sperm are, so we have to aim fairly high in order to get a healthy embryo. We'll end up with fewer embryos than what we started out with in terms of eggs. So once we have the eggs and the sperm, we'll combine them, and over the course of a week, we'll see how many make it to the finish line. So in the laboratory, the first test is survival. Whatever makes it to that 1 week mark has already demonstrated a survival advantage, and that gives us some information about which embryos are more fit. At that 1 week stage, you can choose to either get more information by removing a few cells from the embryo. So what started out as a single egg cell and a single sperm cell becomes what's called a blastocyst embryo at that 1 week stage, and it has between 100 and 200 cells, and you can remove a few cells from the outside of the embryo. That outer part is called a trophectoderm, and the inner part is called the inner cell mass. We're removing the cells from the trophectoderm because that part is destined to become the placental cells. We take somewhere between 4 to 8 cells from the outer part, and those can be sent off for genetic testing by extracting the DNA from those cells. The embryos are frozen while the cells go off. Now this test is actually optional, it's not mandatory or required, but the testing is called pre-implantation genetic testing. The testing can be used to look at different things. So even though the cells are removed and the DNA is extracted, it's not true that we're only doing one kind of DNA evaluation. The most common evaluation is what we call aneuploid testing, and that means we're just counting the chromosomes. So we're trying to make sure that the embryo has the correct number of chromosomes, and we know humans have 23 pairs of chromosomes, so we're just counting to make sure that the embryo has 23 pairs of chromosomes, and the last set of chromosomes determines the sex of the embryo. So XX would be female and XY would be male. If we also knew that one of the parents or both of the parents had other genetic risks, such as maybe they had a single gene mutation for cancer or they had a single gene mutation for a childhood illness, then we could additionally test for that single mutation, and then we would be doing PGT for mutation. Additionally, if we knew that there was other genetic risk factors, we could also be testing at the same time. So we aren't necessarily doing those additional tests unless there was a reason to do those additional tests. So now you're about 3 weeks into the process. You did 2 weeks of injector medications. You did your surgery. You're home recovering. Your embryos are in the laboratory, and you decide whether or not you're going to do the genetic testing, which of course is optional. In my practice, a lot of our patients want to do the genetic testing, but it's certainly not necessary. The older you are, probably the more useful it might be. Why? Because it helps you kind of get to the finish line in terms of knowing which embryos are giving you the highest chance of success, and in my opinion, more importantly, which ones are less likely to result in miscarriage. Miscarriages do slow down your reproductive endpoint, meaning if you have a miscarriage, it sets you back, and miscarriage rates certainly get high as you get older. The other benefit of doing the embryo testing is if you're starting your family later in life and you want to have multiple children, it allows you to identify how many healthy embryos you have. And so if you're getting pregnant now and you want to have children in the future, it helps you really plan your future options. So testing is really a controversial issue, and it's really a personal decision, but these are discussions you want to have with your reproductive endocrinologist. Now that you've had your retrieval, about 10 to 14 days after your retrieval, you should be getting a menstrual cycle. If you decided to do what's called a fresh embryo transfer, you would have been putting the embryo back in when it was a blastocyst, and any additional embryos could have been frozen. If you decided to do the embryo testing, most doctors would have been freezing the embryos. And then in many instances, even if you don't do the genetic testing, many doctors today are freezing embryos with or without the genetic testing. There is some evidence increasingly that putting embryos back in patients who just went through all those hormones have lower pregnancy rates because the uterus is very altered with all those hormones. More recent data suggests that putting an embryo back in fresh in a stimulated uterus may lower pregnancy rates, and even though a frozen embryo occasionally doesn't survive the thaw, and in fact most of the time it does, you might be better off freezing all the embryos because the loss of embryos is lower than the loss of pregnancy rate due to a stimulated uterus. So it's really something, again, you want to discuss with your fertility doctor. Sometimes in older patients, they don't get as many eggs, and so the hormones may not be as high, and it might make sense to put back the embryo fresh without testing or without freezing, but these are discussions, again, you want to have with your reproductive endocrinologist. So now you've got potentially embryos frozen with or without a transfer, and the next step is to wait for your period and make a decision about if you're going to do a transfer if you haven't already done one. So the next month, you potentially could do an embryo transfer. If you didn't get what you wanted in terms of the number of embryos, or unfortunately you didn't get any embryos, then you can make decisions about whether to collect more eggs and harvest again, or to take a break. Maybe you have some important family decisions or travel coming up. It doesn't matter how long the embryos are frozen, it doesn't really alter your pregnancy rates, but you want to make sure that you're available and not traveling for the next steps too much, because you want to be ready to do the transfer and stay put for your first trimester. So now prepping for the embryo transfer is going to take a longer time, but it's not as intense. So we'll be seeing you less often for the embryo transfer, and of course shots are involved. Shots are involved in pretty much everything we do, but you'll also be taking some pills. And so there's many different protocols for embryo transfers, but generally speaking, there's either what we call a natural or natural modified protocol or a medicated protocol. So a natural protocol would involve following your menstrual cycle, assuming you menstruate normally, and then finding out when you're ovulating and putting the embryo back in at the time that normal implantation would occur. And that's roughly a week out from ovulation. Some people add back some hormones to support implantation, some people don't, and there's really different reasons for doing one or the other. These are questions, again, to discuss with your fertility doctor. Then there's the medicated protocol, where instead of following the natural cycle, you're given hormones to replicate the natural cycle. And so you would be given estrogen and progesterone to develop the uterine lining to the stage that it would normally be during implantation. And so you would be taking estrogen, progesterone, and then roughly 3 to 5 weeks, depending on the specific protocol, the embryo would be inserted into the uterus using a small tube called a catheter into the uterine cavity. Now, unlike the retrieval where you put to sleep, for the embryo transfer, generally people are not put to sleep. It's very similar to a pap smear, and so it's a little uncomfortable because of the speculum, but generally speaking, most people tolerate that pretty well. For my patients, I usually recommend that once the embryo goes back in, I prefer they don't travel for the first 10 weeks or so of pregnancy. These are questions to discuss with your own reproductive endocrinologist. You'll stay on hormones if you've started the hormones for your protocol, in my practice, for the first few weeks of pregnancy until you're in the care of your OBGYN. So the day of the embryo transfer, it will be very similar to a pap smear. Some doctors recommend bed rest, not all doctors do. I usually have my patients do bed rest the day of the transfer plus 2 more days. I don't have too many restrictions in terms of the position that they're in, but I do like them to be down for those days. Other doctors don't care at all about bed rest, and these are kind of personal decisions based on their own practice style. Pregnancy test happens about 10 days after the embryo transfer, and then in our practice we keep our patients until about 10 to 12 weeks of pregnancy, in which case they get transferred back to the OBGYN. Most patients, if they've been on hormone replacement, are going to stay on hormone replacement at least in some form for the first trimester. With weaning occurring during that first trimester, you'll be seeing typically your OBGYN or fertility specialist during the first few weeks of pregnancy, depending on which area you live in. Sometimes you'll see the fertility specialist, sometimes you'll see the OBGYN. So IVF cycle cost really varies. Generally speaking, an IVF cycle is going to be affected by the amount of medication you need, whether or not you're going to do genetic testing, the area that you live, but roughly speaking, you can expect to spend somewhere at least $15,000 to $20,000 for the retrieval phase. And then if you have embryos banked, doing an embryo transfer cycle is roughly going to run you $4,000 to $5,000. Again, it depends on the area that you reside. Not all retrievals are going to result in frozen embryos, but if you have frozen embryos, you can consider that you might get multiple pregnancies from that retrieval. And certainly the younger you are, the more eggs you get, the more efficient that cycle is going to be, because you might have multiple embryos to work with, which means you might end up with multiple pregnancies from that single retrieval cycle. And so that's another reason to consider moving to in vitro sooner than later. A lot of times people think about in vitro as kind of a last resort treatment, but if you think of it more as kind of a preventive or doing it sooner, you actually have much better outcomes, and then you can think of it as a family building, proactive step rather than a last resort kind of treatment. Although IVF can be very expensive, it's partly because there's so much involved with it. There's lots of monitoring, the medications are costly, there's a lot of technology and equipment that goes into it. There's a lot on the horizon in terms of coverage, increasing insurance. There's different financing companies that offer great packaging. And so if you're interested in learning more about IVF and those policies and packages that are available, please reach out.